Okay, chapter 13 in your Williams and Hooper. This is bioterrorism. So thinking about bioterrorism, this would be the intentional release of whatever type of pathogen that you're dealing with that can cause harm to people, animals, crops, water, anything that can get put someplace that can cause harm to anybody. So if we put it wherever we could put it, that could cause harm to people. So early detection and management is going to be the key to that containment of bioterrorism. So I would like to hope that we don't see bioterrorism, but we know that it's out there. We know that certain countries have very lethal diseases that they can unleash. We've actually, look at COVID. COVID was a virus that was let loose in a lab and how it went worldwide. So think other countries and us have things in these level 3 labs that are exclusively there, man-made and manufactured, that can cause harm. So we have to be alert of any disease that doesn't really occur at a specific time or place, has atypical manifestations, and occurs in a specific community or a group of people. So with that being said, you would think about if you're working in the emergency room and we see several people come in and they're exhibiting the same symptoms. They have the same things. They've been to the same places. They've done the same things. And then we get another influx of the same types of people. We're starting to figure out a pattern. Where did this come from? How do they get it? What is it mimicking? So we start looking at things like that. And that's very important because some of these diseases have to be caught quickly, because if they're not, they can take over their bodies. So it's important that we catch them, we recognize what they are, and we treat them. So a lot of bioterrorism agents are either bacterias, viruses, or toxins. So those are the 3 things that they're going to be putting out there. And one of the bacteria is anthrax. So we've had scares with anthrax many times, but it's a bacterial disease. It's Bacillus anthracus, and it comes in 3 forms. It's inhaled, so we're going to breathe it in. Cutaneous, it's going to be on the skin, or gastrointestinal, it's going to be where you digest it. There's no isolation. We don't isolate these. We use standard precautions, so anything that we would use with anybody else. This is fatal if we don't treat it, but we do have an antibiotic that can treat anthrax as long as we catch it in time for it to be treated. So anthrax comes in the 3 forms. So what if we get inhaled? If we inhale it, what symptoms are we going to see? Well, we're going to have fever, cough, shortness of breath, muscle aches, confusion, sweating. Now, prevention, there is a vaccine for only high-risk patients. Now, treatment is all the different antibiotics, but if you look at those signs and symptoms, and I'm sitting here looking at those, that could be the flu, that could be TB, that could be thousands of different types of diseases. So it's really important that if we have a patient come in, or 2 or 3 of the same, and they have the same stuff and they've been in the same place, we start looking for similarities and start trying to treat these people. Cutaneous, this is where the symptoms are going to be on the skin. So the lesions may start out to be very itchy. They're going to develop into like a vesicular lesion, which is going to be like a blister. And then it's going to become very necrotic. And it's going to get black eschar over it. And they're going to get fever and chills. So it's going to literally eat away at the skin. And treatment, antibiotics again. So botulism. Botulism is caused by Clostridium botulinum. It is the most potent toxin known. We don't hear much about it, but it would be a biological weapon if it was aerosolized. So if we aerosolized it and put it out into the air where people breathed it in. So what it starts is, it's a neurotoxin. So it's going to do something to our nerves. And so what it actually does, it causes a paralytic illness. Paralytic means it's going to paralyze the body. So what the drug does, it gets into the bacteria does, it gets in and it blocks all your neurotransmissions. It is not contagious. which seems really weird because how do they get it there? It's not contagious. You have to breathe it in. You have to come in contact with it. So if I get it, I can't give it to the next person. I have to come in contact with it. So it's not contagious. So with botulism, remember you have a triad. Triad means 3. So you're going to have 3 things that are going to happen. There's going to be no fever. These people are going to start getting paralysis. So they're going to start with paralysis. It's going to be symmetrical, so it's going to be on both sides. Descended, flaccid paralysis with prominent bulbular palsies. So they're going to start getting paralyzed from here, and it's just going to start going down the body. And the worst thing is these people are going to know their mind is going to be sharp, and they know what's happening, but they're not going to be able to talk because they're going to be paralyzed. So they can't talk, but they know what's going on. They can't move their body, but they know what's going on. So it's very scary, and this can kind of come on very quickly. So it's something that we need to recognize when they first come in, if you got a patient that's coming in and they're having these types of symptoms. So how do we treat it? Well, there is a medication, but we got to catch it. And, it's hard to sometimes catch these diseases when they first come in. But one of the drugs is trivalent. It's ABE. It's an equine antitoxin. So we get it from horses, and it prevents the progression of the disease. So if we catch it early on and we can give them this, then we can stop it from progressing any further. However, if we don't catch it early, we don't realize what we're treating, and it has progressed to the point that their respiratory muscles are paralyzed, then we're going to have to do supportive care. We're going to have to monitor their airway, make sure they have a gag reflex, coughing, swallowing. We may have to put them on a ventilator and breathe for them for a certain length of time until we can prevent any more progression of that disease. Morbidity and mortality is pretty high if we don't catch it early. Now, it is not transmitted person to person again, so we're going to use those standard precautions. Standard precautions, which we've already talked about. We're going to wash any exposed clothes, shower if you've been exposed, like if the botulism has been aerosolized, you're going to want to shower. Use bleach to the surfaces of everything. That's going to kill everything out. Now we're going to talk about the plague. There's 3 different kinds of plague. Bubonic. When you think of bubonic, I want you to think of this bubonic plague. I want you to think of lymph nodes. Lymph nodes are going to get swollen and painful. Bubonic. Then you're going to think of septicemic plague. This is going to affect the entire body, all over. And then pneumonic. Think of pneumonia. So you're going to think of lungs when you think of pneumonic. So the plague. It's caused by all 3 of those. All 3 of them are caused by Coccobacillus Yersinia pestis. So all 3, bubonic, septicemic, and pneumonic are all caused by Yersinia pestis. Usually it's a bite from an infected flea. We get it through direct contact, either direct contact or we have to inhale the droplets for respiratory, for the pneumonia. The infected bite is probably going to give us the bubonic. Respiratory failure, if we do not catch this and it goes into the pneumonic one, respiratory failure is going to be within 4 days. And I could see, we don't see bubonic plague very often. It was a plague that went through overseas years and years ago, and it was actually caused by a bite of a flea, gave it to like rats, and then the rats gave it to the people. So, but it's a biological attack. If we were to have a biological attack, it's probably going to be the pneumonic plague because it would be easier to aerosolize those and put them out in where you have to breathe them in. So, and you can think if someone comes in the hospital and we really don't know what's wrong with them and they go into respiratory failure in 4 days, we may not know what's wrong with them. And it may take us 4 days to figure out what's wrong with them. And by that time, we're too late to treat. So we need to be aware of all this and where it's at. So then incubation period is 2 to 4 days. So incubation period is very short. So if you get one person coming in, they should have all been exposed to it. You should see more people coming in with the same type of symptoms. So here's the 3 forms. We got pneumonic, bubonic, and septicemic. Pneumonic, think lungs. Fever, headache, weakness, rapidly developing pneumonia, death within 4 days. Now, chest pain, cough, you get all the respiratory stuff. Now, the bubonic is going to be more your lymph nodes. So you're going to have swollen, tender lymph nodes, fever, headache, chills, weakness. And then septic, this is fever, chills, abdominal, DIC, all of those types of things. Gangrene. So know the different types and what things you would see in those types. Okay, so signs and symptoms. We've kind of talked about these. These are signs and symptoms of your respiratory. So look at your high fever, headache, chest discomfort, dyspnea, hemoptysis, GI symptoms rapidly going into your respiratory failure, 2 to 4 days. Treatment. How do we prevent the plagues? Well, contact precautions until decontaminated or until those bubonic, the ones that are in the lymph nodes, until they're not draining anymore. So they will have to have contact precautions until those lymph nodes are not draining anymore. And usually it's droplet precautions. Well, that would be for your bubonic and your septic. So contact precautions until everything is not draining, if anything is open or draining. And then droplet precautions until 72 hours after antibiotics for the pneumonic. So once they've been on antibiotics for 72 hours, you can stop the droplet precautions, but you don't have to use those. But then your contact is going to be for your bubonic and your septicemic if there's anything draining. And then treatment, it's going to be antibiotics, streptomycin, gentamicin, tetracycline, doxycycline. So we do have treatment for those as long as we catch it early and we can get it treated. Smallpox. Smallpox has been eradicated from the United States, so we used to vaccinate against it, but we don't do it anymore. It is required if you travel to other countries, but it's caused by variola major. It is a virus that comes in. This one's the one that I would worry more about, but we eradicated it back in the 80s. They consider it a low risk agent, so they consider it kind of low risk that we're not going to use it as a biological agent, but it's highly, highly, highly infectious. So it is airborne, so anybody that comes in contact can get it. So it's 30% fatality rate, so I think that's fairly high. It is a public health emergency. If we get a case of smallpox, we will have to kind of really figure out where it came from, isolate those people, put them in, keep them separated from other people. Incubation is 7 to 17 days. So, if you're exposed and then you don't get it for 17 days, it's really hard to know where was I 17 days ago and how did I come into contact with it. And then there is isolation precautions with this one. It's very, very strict standard precautions, contact, and airborne. So we're doing every precautions that we can think of. You're going to wear your N95. They're probably going to be in their negative pressure room. And it's very important that you really protect yourself from this because it's very highly infectious and airborne. Okay, so symptoms. What are you going to get with smallpox? 1, high fever, fatigue, severe headache, and then you're going to get that rash 2 to 3 days later. Or they're called the pox. You'll get those pox and they come all over and they usually leave scarring and stuff like that on the skin. There is a vaccine. So if you know you've been exposed, you can get a vaccine within 4 days of exposure. However, you saw the incubation period, 7 to 17 days. Many people might not even know that they've been exposed. So if you don't get the vaccine in time, it's not really going to help any type of prevention. So it has to be within that 4 days. Treatment, it's supportive care. So supportive care just means we're going to support what they have. So if they have fever, we're going to give antipyretics. Fatigue, we're going to give them rest periods. We're going to cluster their care. Headache, we're going to give them medications, ibuprofen. Vomiting, we might give them antiemetics. All of that stuff. Provide good skin care. Make sure we keep those pox clean and dry. Antibiotics, because those lesions on their pox can get infected. So we would use antibiotics for that. So The other one that we're looking at is called viral hemorrhagic fevers. This is Ebola or yellow fever. So this is in your ATI book. It's not in your textbook, but the symptoms of this one is fatigue, kidney failure, elevated temperature, nausea, vomiting, internal and external bleeding. So with Ebola and yellow fever, the biggest thing is going to be bleeding. And internal and external bleeding, they're going to go into shock, liver's going to shut down. Prevention, there is a vaccine available for yellow fever in certain parts of the world. I don't think there is a cure. There is a vaccine for Ebola. But treatment, no cure, supportive care only, minimize any invasive procedures that we're going to do. So we're just going to try to support them, hope we can get them through. If not, support them all the way through the end. You know, support their respiratory. So we're going to cough, turn, deep breathe, ventilate, you know, secondary antibiotics, maybe to treat secondary infections, you know, push fluids, comfort measures, medications, things like that to help them be more comfortable. Okay, so that is the end of bioterrorism.